like to express my gratitude to Tam and to Marco, but also to Klinikpartnerschaften for making this event possible. And my gratitude also goes to Rabea Fischer, my former doctoral student. So she's now Dr. Fischer, who is really the best person to deliver this workshop because she has a vast experience on patients with psychosis, but also with metacognitive training. And I would like to announce that in September, I will visit beautiful Vietnam together with Jonas Petter to deliver a workshop myself. And yeah, that was my introduction. Sorry for being so brief, but in the north of Germany, we usually do not talk too much. So I would like to hand over, I think, to Marco now.
I think I will present a little bit about the program, the cooperations between Charité and diverse partner in Vietnam. Thanks a lot, Professor Stefan Moritz, to share with us also the history of the MCT program. And we learn a lot from the MCT program. And today we are very excited to learn from the program and to also have, I think it's the first idea for some colleagues. Of course, we had before the presentation of Dr. Marco Sierhut, but today we have really the practical part. And also thus we are happy to announce that we will have the workshop in present at the Hanoi Psychiatric Hospital in September. So you are welcome if you live in Hanoi, and we also you can also join with us. And now I would like to present very short about the program from the cooperation program between Vietnam and Germany in terms of mental health care. And I have some new project to present to you, and I'm happy that you, some of you maybe join with us and also contribute into the network German-Vietnamese cooperation for mental health. So I would like to share my screen. Yeah. So can you see my screen? I think not. You cannot see my screen.
Yes, we can, but it's not the presentation mode yet.
Okay. Okay, I will try to.
Rõ, nhìn rõ rồi đấy Tâm ơi.
Nhìn rõ được cái
Nhìn rõ mà
cái
cả
màn hình của
trình
em
chiếu.
đúng không ạ?
Đúng rồi, Tâm để chế độ trình chiếu đi.
Vâng ạ. Được chưa? Mọi người nhìn thấy chế độ trình chiếu chưa?
Nó hơi bé.
Yeah.
Được rồi, ok rồi đấy.
Được rồi ạ. Em cũng xin được giới thiệu về trường Đại học Y Charité. Chắc trường Đại học Y Charité thì năm nay đúng là tròn 10 năm trường Đại học Y Charité đồng hành với các đối tác tại Việt Nam ở các đối tác tại Việt Nam về lĩnh vực chăm sóc sức khỏe tâm thần. Trường Đại học Y Charité thì cũng là một cái niềm tự hào của chúng em là từ năm 2020 thì liên tục một trong những bệnh viện đứng đầu của thế giới. Hiện nay thì năm 2025 là đứng thứ 5, đứng thứ 7 ở trên thế giới trong ranking và đứng đầu của nước Đức. Trường Đại học Y Charité thì có truyền thống từ trên 300 năm với 4 giải thưởng Nobel là các giảng viên cũng như là cán bộ của trường Đại học Y Charité, và tiếp nối truyền thống đó thì một trong những cái hoạt động rất là tích cực của trường Đại học Y Charité đó chính là hợp tác quốc tế. Trường Đại học Y Charité thì hợp tác với trên 300 trường đại học khác nhau ở trên thế giới, trong đó thì cái mảng cũng khá là mạnh là các nước đang phát triển, các nước có thu nhập thấp và đang phát triển. Trường Đại học Y Charité thì official là từ năm 2018 thì đã nhận được những cái funding của các tổ chức chính phủ của Đức, trong đó có chương trình hợp tác bệnh viện cũng như là chương trình trao đổi DAD. Thì chúng tôi hợp tác với các lĩnh vực như là tâm thần, sức khỏe giới tính hay là nhi khoa, trị liệu tâm lý và cả bên y tế công cộng với rất nhiều các đơn vị khác nhau. thì đây cũng và đa dạng hóa các đối tác và tổ chức của trường đại học Y Charité. Thì các dự án tiêu biểu của trường đại học Y Charité hiện nay tại Việt Nam, trong đó có Asian Bipolar Network Việt Nam, thì rất là may mắn là Bệnh viện Tâm thần Hà Nội cũng là một site của chúng tôi, và chúng tôi đã có trên 35 site. Đồng thời là hiện nay thì cũng có một dự án hợp tác với Hội Tâm lý trị liệu Việt Nam, Trường Đại học Quốc gia Hà Nội để phát triển cái mạng lưới quốc gia trong việc đưa trị liệu tâm lý có dựa trên bằng chứng khoa học vào Việt Nam. Thì đây là những cái hoạt động hiện nay của chúng tôi, thì cũng xin được giới thiệu với mọi người là tháng 9 thì chúng tôi cũng có tháng 9 chúng tôi cũng có tổ chức một chương trình ứng dụng liệu pháp hành vi biện chứng trong trị liệu tâm lý cho thanh thiếu niên. Thì các bạn muốn tham gia cũng có thể đăng ký tham gia. Đồng thời là chương trình này nằm trong cái chương trình hợp tác với Bệnh viện Tâm thần Hà Nội để xây dựng cái đưa ứng dụng của huấn luyện luyện tập siêu nhận thức trên bệnh nhân loạn thần với tới các bệnh viện tại Việt Nam, bệnh viện tâm thần tại Việt Nam. Và đồng thời là chúng tôi cũng đang có một cái dự án xây dựng chương trình phòng trầm cảm sau sinh tại Việt Nam, và cũng mong rất được sự ủng hộ của các anh chị và các bạn. Đặc biệt là chúng tôi cũng vừa nhận được funding của tổ chức Wellcome Trust, một trong những tổ chức lớn nhất về các funding trong lĩnh vực sức khỏe trên thế giới hiện nay. Thì có chủ đề chính là sử dụng AI để dự đoán sớm tiến triển trầm cảm nặng và kéo dài tại Việt Nam. Tiếp cận dựa trên phân tích mạng lưới và sử dụng AI. Thì chương trình này cũng rất là mong muốn Bệnh viện Tâm thần Hà Nội sẽ cùng đồng hành với trường đại học Y Charité, cũng như là chúng tôi cũng đang có một dự án đang xin được triển khai trong việc chăm sóc sức khỏe tâm thần của trẻ thanh thiếu niên, phòng trầm cảm và lo âu. Cũng rất mong trong tương lai tiếp tục hợp tác với các bệnh viện tại Việt Nam trong những chương trình này. Và tới đây thì tôi cũng xin giới thiệu lại toàn bộ network của chúng tôi tại Đức cũng như là tại Việt Nam, cũng như là những nhà tài trợ cũng như cũng đối tác cộng tác với chúng tôi. Thì chúng tôi rất là cảm ơn những đối tác, bởi vì là chúng tôi ở đây muốn thành công được thì cũng không thể thiếu được đối tác. Trong đó có giáo sư Stephen Morgan, cũng như là những nhà tài trợ, các tổ chức đã tài trợ cho các dự án của chúng tôi từ trước đến nay. Và xin chân thành cảm ơn các anh chị, các quý vị đã chú ý lắng nghe. Và tôi xin nhường lời cho tiến sĩ Marco Siwood, chủ nhiệm dự án MCT tại Việt Nam hiện nay. Marco, I will hand over to you. Thanks a lot to join with us, and you are the PI of the MCT program, and we are happy to hear some word from you. Thanks a lot.
Thank you very much. I will also share my slides quickly that I prepared for today. Can you see them?
No.
No? Wait a minute. No. Okay, now you see them, right?
Yes.
Okay, perfect. Yeah, thank you very much for joining us as well. I also want to just give a quick overview on the project itself, why we and I think it's an important project as well. And the focus should be that our patients will benefit from it. And so the main topic of the project is metacognitive training, MCT for psychosis, and its implementation in Vietnam. My name is Dr. Marco Siwood, and I'm a senior consultant, and I'm leading the area for psychotic disorders at the campus Benjamin Franklin at Charité. So this is also the treatment of schizophrenia, a focus of my clinical and research work as well. Here are disclosures that I wanted to show as well. And otherwise, I want to start with diving into why it's important to have different treatment options for schizophrenia. We know that schizophrenia spectrum disorders are a very severe mental disorders with a very big range of symptoms, as we know now, with positive symptoms, negative, cognitive, affective, psychomotor symptoms. So it's a very severe and very complex disorder. The most known symptoms and the most severe symptoms are the so-called positive symptoms, as you know, and part of the positive symptoms are hallucinations, but also delusions. And I just want to focus on delusions because this is what MCT for psychosis is aiming for. And I think it's important to remind ourselves what delusions are or how delusions are defined. So a very famous psychiatrist, Jasper, said that there are 3 points for delusions, and it's subjective certainty, uncorrectability, and the impossibility of content. And you also find this in the definition at the DSM. It's a false conviction due to incorrect conclusions about the external reality. So you will hear this throughout the workshops again, but I just want to give a quick short introduction to that. And especially the 2 points, subjective certainty and uncorrectability, are the aim of metacognitive training for psychosis. So as I mentioned, schizophrenia is a very complex disorder, and this is why we also have to work at a multi-professional team to treat our patients and give the best help. So the patient is always in the center of the treatment. So we try to get the best results for our patients by the treatment. And this is why we have to work hand in hand as physicians, psychotherapists, mental health nurses, social workers, and many, many more to get the best outcome. And this is why the metacognitive training and the clinic partnerships do focus on a multidisciplinary capacity building as well. And this works very well in Vietnam. So I'm very impressed what Professor Ta did achieve already with the different clinic partnerships now so far. And I'm very happy that we are part of that as well with the partnership with the Hanoi Psychiatric Hospital. And metacognitive training has the benefit that it can be offered at a different group of people. It can be offered by psychologists, psychotherapists, but also by doctors and physicians, also the mental health nurses, and many more. And this is why it fits well in the network of community-based mental health services that includes general healthcare, community healthcare services, but also mental health beyond the health sector and all the different group of people who are working in this area. Also, for example, occupational therapists that we didn't mention so far. And as we know, we have 3 pillars of treatment for schizophrenia, and metacognitive is in the pillar of psychotherapy. So it's a form of cognitive behavioral therapy, and it's something that we can offer easily to our patients in the outpatient and also in the inpatient department. So it is like part of an overall treatment plan for all the individual patients. And I just want to give you insights in our active global partnership, what we did so far and what are the plans for the next year that is still coming. So as mentioned, the MCT for psychosis is addressing a gap in the treatment of psychosis through low threshold metacognitive training. And the benefit is also that it's freely available also in Vietnam. So as I mentioned, it is part of the partnership with the Hanoi Psychiatric Hospital and the Charité Hospital in Berlin. But we have the collaboration with the University Hospital in Hamburg, where Stefan Moritz is based as the founder of MCT. And the planned activities include that we want to adapt MCT, we want to translate it, but we also want to adapt the materials to the Vietnamese context. And we want to do the online workshops, and this is what we do now. So this is our first online workshop for that. And it's also part of the adaptation as well. So I think it's very important that when you see and say, oh, I didn't understand that, for example, there are different pictures or different sentences. If you have the feeling, I don't really understand, I don't get what you mean, give us a feedback, tell Rabia Fischer, who's giving the workshops, because we can use that information for the adaptation of the materials to Vietnamese. Then there will also be, as already mentioned, on-site workshops. We had our first workshops last year. I think it was exactly 1 year ago in July 2025. And as already mentioned, there will be the next on-site workshop in September. So we will be at the Hanoi Psychiatric Hospital from the 14th of September to the 18th of September. And you will get more information on the program by my colleagues as well. And the idea is also that we train people and then they will be trainers as well. So it's the ideas of a train the trainer program. And the result should be that we want to have a structured new psychotherapeutic intervention for schizophrenia in Vietnam that is suitable for the multidisciplinary team that I mentioned before with mental health nurses, psychotherapists, clinicians working hand in hand. And we also have the idea to train more than 200 specialists in MCT by this train the trainer idea that we train people and these people can train other people as well. So we will get a bigger population of people who can offer this treatment for our patients who should benefit from that in the end. So maybe an overview, Dr. Fischer will mention that as well, why metacognitive training. So as I said, the objective is thinking about thinking. So it's the reflections of one's own thinking, and we want to reduce the cognitive distortions or in the pathogenesis of delusions especially. And it's good because it's a group training. So 4 to 10 patients can join the training. So it's not a only one-by-one treatment therapy. Also for human resources, it's beneficial because up to 10 patients can join the metacognitive training. And we do have a lot of background information already because the MCT that Professor Moritz developed is already available in 39 languages. And in Germany, it's even included in the official treatment guidelines for schizophrenia now. It's an open source version, so it means that it's freely available. And also there is a mobile app version coming and developed, so-called Cogito. So these are a lot of things that are pro MCT for psychosis also in Vietnam. And just so you see what will come as well, so there are different modules, like up to 10 modules with different foci. You will hear a lot about more during the workshops. I don't want to go into detail, but just you see that there is a structure that you can follow from module 1 to module 10, and you will get the information by Dr. Fischer during the workshop. And I think it's very important to mention that we take time to develop MCT for psychosis in Vietnam and in Vietnamese, because I think a culture-sensitive medicine is very important. And this is why the clinic partnerships have a very big benefit in developing treatment options in different countries, giving this information, because it's different in Argentina, for example, where MCT has been developed as well, different in African countries and Asian countries, and also different in Vietnamese, for example, because we want to focus that all the patients and the trainers do understand the treatment the best way. And I just want to give an example in the end. What does that mean? So when we talk about cultural adaptation, for example, there's also MCT for depression. We focus on MCT for psychosis, but there's MCT for depression as well. And it has been used for refugees in Germany as well, with a focus on Arabic and Farsi speaking patients. So we also had to adapt the training material or the group of Professor Moritz. And so there had been workshops like we have it here as well with experts in psychotherapy, medicine, research to adapt it to language communication. So we had also communication scientists, and it was important to identify the wording, the phrases and pictures that may be inappropriate as well. And they had to be adapted for MCT for depression in the Arabic speaking language. And this is what we want to do for the MCT for psychosis in Vietnamese as well. So thank you for every feedback you will give us, because I think we have to work hand in hand. It's not that we want to just give you information and teach you. We are depending on your feedback, and it's a project that we work hand in hand, because we also do learn a lot by your feedback, a lot by the comments you give us also for the patients. So thank you very much already in advance. And with that, I just wanted to give a small introduction. I thank all the people in the work group, especially with the project of the clinic partnerships as well, Professor Stefan Moritz and Rabea Fischer as well, and the colleagues that will join the on-site workshop in Vietnam. And I think I don't want to hold you back to start with the workshop. So thank you from my side again. And if there are any questions, you can message me anytime as well. Okay. Tam, you want to say something more before Rabea starts?
No, thanks a lot, Marco. And I think is now I would like to maybe the short word for Dr. Rhea Fischer. Tiến sĩ Rhea Fischer là một nhà tâm lý học lâm sàng và một nhà nghiên cứu của nhóm nghiên cứu thần kinh tâm lý học và tâm lý trị liệu, khoa tâm thần và tâm lý trị liệu của trường đại học y khoa Hamburg Eppendorf chị cũng đã cùng tham gia phát triển và đánh giá hiệu quả của liệu pháp huấn luyện siêu nhận thức, đồng thời ở trên bệnh nhân tâm thần phân liệt. Và chúng tôi rất là vui ngày hôm nay là chị đã dành thời gian để thực hiện cái buổi workshop ngày hôm nay cho chúng ta. Và tôi xin được mời chị Rabia Fisher có thể trình bày. Yeah, now is the stage is yours, Rabia.
Thank you so much, Tom. Thank you everyone for coming today, and hopefully we will have a great workshop. I would like to thank first Dr. Zierhut and Professor Ta and Professor Hahn for creating this project and asking me to join again. Of course, to Professor Moritz for giving me the opportunity to come here today again to talk to you about MCT developing or furthering psychotherapeutic options for the treatment of psychosis is something that is really, really dear to my heart. And I can add and continue with so much of what has already been said. So I'm very excited. And just one thing in specific that I would like to pick up from what was said in the beginning, in the introduction. The professor from Hanoi Hospital said in the introduction that one of our aims is to get patients back into the community. And I think that is something very, very central. And we really hope, and we can see from our work here in Germany and in other countries where MCT has been established already, that it can be one of the elements of one of the pillars, as Marco Zierhut pointed out, of the treatment for patients with psychosis. And I do really think one of its strengths is that it is very easy to implement. It can be facilitated by many different people from different professions. And I do think we have a really great chance to have it be established throughout Vietnam as it has been throughout other countries. So I'm very glad, very happy to be here today. And I will just take a moment to open my presentation. Okay, can you see it properly now? Yes? Yeah, okay, thank you.
Yes.
Okay, maybe before I start into the workshop, I just want to let you know that the best way to do this is really to interact with each other. So anyone who is participating either online here or at the hospital there, I will give examples, I will present examples of the training to you, and I will ask throughout, what do you think? If you were a patient in this training, what would you answer, for example? And I kindly invite you to just give me your opinions, to kind of imagine that you were a patient or a person attending this training, so that you can get an idea of how these exercises work and how we do them. And I will jump right into the first slide in 1 second. But before we start, I will just briefly mention that we have come up with an outline for the day. So we will try to take little breaks of about 15 minutes every 90 minutes. So we will take a break every once in a while. And if something else comes up, please just let me know. Okay, so if there is nothing for right now, I don't think that is the case, then I will just jump in with a first exercise. And if you just have a look at this cutout, this is one part of a larger picture. And the question here is, what does this person feel or do? We have 4 options. Could it be a final pleading in court? Could it be a labor leader who speaks to his comrades in the 1920s? A fight at the marketplace, or a musician singing a love song? And I think most of you will have had a look at it by now and will have a first idea of what you think might be the right answer. And I will just reveal what the answer is. And hopefully not everyone guessed that this was the answer. And this is really how MCT works. We use simple exercises that are entertaining, that are easy to understand, and that keep our patients, our participants, motivated in what we are doing. But as Dr. Zierhut has already mentioned before, this is always based on a theoretical background, an idea of why we are doing this. And one of our main goals is to reduce overconfidence. One of our other main goals is to reduce hasty decision makings. And this is just one of the many examples of how we do this. So just a brief overview of what I would like to do today. So I will just introduce the training again, the rationale, the structure, and the clinical administration. This is a lot of what was already mentioned before, and we will then go through the different modules, and I will tell you a little bit about the research findings that the modules are based on, and then how we translated these research findings into the actual modules of the training. And we will try and see how administering MCT works in everyday life through the exercises that I will show you. Okay, so what is metacognitive training and why do we need it? As mentioned already, it is an evidence-based group intervention, and the aims are to improve metacognitive skills and to reduce cognitive biases. And the reason why we need it is that cognitive behavioral therapy for psychosis is widely recommended by treatment guidelines, but it is rarely implemented in clinical practice. This is not only the case in Vietnam, but it is also the case in many other places. We still have, a lot of room to have more psychosocial interventions for psychosis implemented in everyday clinical life. And even here in Europe, especially in the beginning, so in the early 2000s, when the work on this started, as Professor Moritz pointed out, there were really not that many psychosocial interventions for psychosis that were based on scientific evidence, that were implemented in clinical practice, even though they are recommended. And this is where MCT comes in, because it is really easy to establish. So the reason why MCT was developed in the first place is that there was literature showing that there are specific cognitive biases in psychosis that appear over and over again. One of them is jumping to conclusions or hasty decision makings. One of them is overconfidence. And one aspect is a difficulty to consider alternative explanations. And these are things that also relate to the definition of the delusions that Dr. Zierhut showed previously by Karl Jaspers. So this is where MCT directly addresses these fundamental aspects of the delusions. And even though these findings were consistently shown in the literature, they were really not translated into everyday clinical care that much. And so this is why MCT was developed. Professor Moritz just said in 2003 they started. Here it says 2004. So early 2000s is when it began. And throughout my presentation, you will see this little looking glass and then this little gear over and over again. And the idea is that we have the research findings, and then we will show you how we implement them into the therapeutic practice. So the question is, what do we mean by metacognition exactly? There are different definitions of metacognition out there, and different people may think of different things. The way we view metacognition is based on Flavel's definition, which is just a very broad general definition, stating that metacognition is one's own knowledge about one's own cognitive processes and anything related to them. And to simplify this a little bit, because this is not something that we can easily discuss with patients, is we say metacognition means thinking about your own thinking. So the idea in MCT is that we say it is human to make mistakes. Everyone makes mistakes. Everyone is wrong sometimes. That is completely normal. But things like overconfidence can, in the long run, lead to developing delusional thoughts. And in MCT, we try to always highlight the relationship between the exercises that we do, like the picture you saw in the beginning, and everyday life and psychotic experiences. And what we want to do is to encourage participants to slow down their decision-making, to gather more evidence before they make decisions, to tolerate uncertainty, and to consider alternative explanations to situations. So our overall idea or our goal is to sow the seed of doubt. So just to slow down thinking and increase awareness of one's own thinking. And what may be a bit unique about MCT, and what is also a bit different from other versions of cognitive behavioral therapy for psychosis, is that we use this so-called backdoor approach, where we don't necessarily speak about the content of the delusions of the patient, but we really try to focus on the mechanisms of the mental processes or the mechanisms of the thoughts. So it is very cognitive focused, whereas other versions of CBT for psychosis, for example, focus more on the emotional aspects or the behavioral aspects. So as mentioned before, MCT is one variant that can be very easily combined with other versions of CBT. The idea or why MCT might be helpful also with patients who are still very convinced of their delusional thoughts is that we don't directly challenge the content of the thoughts, but we try to go through this cognitive route to increase doubts and then to slowly kind of undermine the delusional thoughts that the person has. yeah, and this is mostly what I already said. So CBT focuses on the symptoms and the individualized formulation of treatment, whereas MCT focuses more on the cognitive processes. And both complement each other. This is basically what we already discussed. This is what Dr. Zierhut also pointed out before. So MCT is easy to administer, it's very structured, it's manualized, and especially if it then is adapted to the cultural context of Vietnam, or possibly also more broadly to an Asian cultural context, then it can again be very structured and manualized than in this version of its application. We can use it for inpatient or outpatient settings. We do both here at the University Hospital in Hamburg. There are many different settings that it has been implemented. One of our colleagues has also started an online version of MCT for psychosis, which some of you might be surprised to hear that that's possible, but it has been very successful. So it is possible to do that also. And for us, really the only inclusion criteria for MCT would be that the person shows psychotic symptoms, especially if there is a delusional component to them, and that they are able to function in a group setting. So even if they have active delusions, that is not an exclusion criterion for our setting or for this training. And as mentioned before, it can be administered by various different professions, and you can get it free of charge. As mentioned before, it is an open group format. So the way we conduct MCT, for example, here at our hospital, is that patients who are on our specialized psychosis ward, they can jump in to the group or exit the group at any given time, which is really important for our setting because we are an emergency hospital in the second biggest city in Germany. So we have a lot of patients coming in suddenly, sometimes also being discharged very quickly, sometimes people coming back very often. So the fact that you don't have to start at module 1 and then go through module 1 to 10 in this specific order, but you can just jump in, jump out at any given time, is really, really helpful for our setting. And I imagine it might also be helpful in other settings as well. We have 10 different modules. This is the overview that Dr. Zierhut also showed before. I will show you again in 1 second. And we have 2 versions of each module. We call them 2 cycles, which means that the overall content or the theme of the module is the same in cycle 1 and cycle B, or version 1 and version 2. It's just that the exercises are different. So for example, the first exercise in the beginning that I showed you, the singer, he would be in one version, but then in the other version, it would just be a different picture, but the same exercise. And we tend to do MCT for about 45 to 60 minutes, but this is also one aspect that you can really choose or influence yourself how long the session will take. So every MCT module has a basic structure that I will tell you about in 1 second. It basically has a beginning, an introduction, a middle part, and then an end part. And as long as you do the beginning and the end, you can really choose how much you do in the in-between time. So do you want to have the middle part be so long that you only have about 30 minutes of group, or do you want to have it be so long that it's almost 60 minutes of the group? This is really something that you yourself can decide on either before you do the group, or you can also decide that in the session. For example, we all know that many patients with psychosis have trouble concentrating. So if you are in your group and you notice, okay, 5 out of the 6 people here are falling asleep, or they can't follow anymore, they can't pay attention anymore, then you can just say, okay, let's just stop here for now. Let's just go to the end part of today's session, and then we will terminate the session for today. So this is really helpful, I think, as well for practical application. And you can do MCT once a week or twice a week. Some people even do it 3 times a week. It just really depends on what you can offer in your setting and what you want to offer. And it is ideal if you can do MCT with 2 facilitators. I know it can sometimes be difficult to have the staff. You can do it if you are alone. We just really recommend that it's 2 people. This is not specific to MCT's content. It's just something that is easier to do in general if you do groups that you have 2 facilitators. If, for example, one patient gets agitated and leaves the group, one person can follow after them, ask, how are you doing? Is everything okay? Do you need anything? And then come back. But it's not absolutely necessary. And the materials you will need is some sort of video projector and a laptop. What I have done in one of our wards here is that if you have a very small group and you don't have a projector or anything like that, then you can also just take your laptop and just rotate it so that the patients can see the laptop. So you can imagine if you only have like 4 participants, then they can sit close enough to see the screen. It's just easier if you have a video projector and, of course, a white wall or something to project the slides onto. The other materials that you will need are the PowerPoint slides that are part of the training. Again, if you remember the first exercise, that would be part of that. The manual, the homework, and then a couple of different little things that I will get into in a minute as well. And as said before, the slides, the manual, the homework, all of that is free of charge. The English version can be downloaded from our webpage. The Vietnamese versions, Professor Ta knows everything about that. So if you want to know more about them, you can contact her. So you saw this overview before already. These are the different modules of MCT. Here you can already see. I think you should be able to see my mouse. So we have modules 2 and 7 that cover the same topic, and modules 4 and 6 that also cover the same topic. That is just because, for example, the jumping to conclusions bias is something that we see as so central to the formation of delusions. And then the to empathize modules, this is theory of mind first order, this is theory of mind second order. But as I said before, these modules don't have to be administered in this order. Every single module starts and ends on that day. So you don't have to attend module 3 in order to be able to understand module 5 or anything like that. So for example, what I used to do when I was on one of our wards here, where we had a lot of fluctuation, where you would never know who would be there that day, which patients would be there, what topics would be relevant to them. I would, on that day, based on who was there and who would attend, choose the module that I would administer. This is, of course, only possible if you know the contents of the modules very well, if you feel comfortable to just decide on that day, today I will do this topic. But just in theory, it is possible to do this flexibly. Okay. Are there any questions, comments, remarks until now? I saw there were some messages in the chat, but I don't know if they are relevant for me.
This is only the organization's information.
Okay, thank you. Yeah, if there's anything else, please just let me know, interrupt me. That's completely fine. Okay, so as I mentioned before, we have a basic structure that all MCT modules follow. So we have the introductory part, the beginning, where we introduce the topic of the specific module, and then we have a normalizing aspect. So here is an example from Module 2 concerning the jumping to conclusions bias. This is a slide that shows the explanation or the introduction to the specific bias. So what is this? What are we talking about? And so on. And then we always have slides that kind of show how the specific bias that we are talking about might look like in everyday life, because this goes back to Er is human. So we all fall into these traps. We all have these cognitive biases to a certain degree. This is not something that is unique to our patients, but what is different is that they might have these biases to a stronger degree, and they might also have a harder time noticing that this is a bias. Like, oh, okay, I had this thought. Maybe there is a different explanation or something like this. This is what we might think, right? But someone who is in acute psychosis might have a harder time stopping and thinking, okay, maybe there are other explanations to this, or maybe I should think again and see if I can find more information before I make my decision, things like this. And so we came up with different examples from society to show how the specific bias, in this case, the jumping to conclusions bias, can look in everyday life. This is also something that we have found to be really helpful in building a trusting relationship with our patients, because mistrust or suspicion is a hallmark of many psychoses in the first place. And also, many patients have experienced things that might make them fearful or uncertain in the communication with the mental health care system, for example. So many patients have had very stigmatizing experiences with the community at large. And so having this approach where we say, hey, what goes on with your thoughts? This is something that happens to everyone, right? It's just important to keep in mind that we can be wrong sometimes. So this is a really normalizing, destigmatizing approach, and many of our patients really appreciate this. Okay. And then this is what I called the middle part of the modules before. So we have a part in between the beginning and the end, where first we express in simple terms that everyone can understand what the research findings are. These slides are always titled, "Why are we doing this?" And we also phrased it in a way that says, studies show that many, but not all, people with psychosis, and so on. And this is also very important because sometimes patients react very, they can react badly to this, saying like, oh, are you overgeneralizing? Are you saying that everyone is like this? And then we can always say, no, this just means that studies have found that many people show this. This is not everyone. And so it's always important to not skip what is said in the brackets here. And, oh, sorry. And then we have the section of the exercises. So this is very important because many people miss this aspect, but it is really important to know. There are too many exercises in each module to complete in 60 minutes. That is on purpose. You are not supposed to do every single exercise within one session. There are more exercises than you can do in one session so that you can either see which exercises work best for your setting, your patients, which exercises you personally like best, even if you want to choose through that criterion. But also if you have someone who has attended your group for a while, who might already know the first 3 exercises in this module, then you can just say, okay, we'll skip exercises 1 through 3. And today we will start with exercise 4. And so this person can also participate because they can see an exercise that they haven't seen before. So please, please, if you're doing this, pick and choose which exercises. And if you don't have the time to choose before, just do as many exercises as you can do in the time that you have. And then say, okay, this is enough for now. I have 10 minutes left until I want to end our session today. So now I will end the exercises part and go to the end part of the presentation. Because many people have said before, how do you do this in 1 hour? You're not supposed to do all of them in an hour. And then here we have the ending part of each module, which is always the learning objectives or the transfer to everyday life. So at the end of each module, we say, okay, what do you think we wanted to tell you today? Or what is your personal takeaway message from our session today? And then patients can say what they learned today. It is a repetition of what we discussed during the session, and then you can also show the slides of what we established as the learning goals for the day. And we follow this up with an example again of how the specific bias that we were talking about during that day might be related to psychosis in everyday life. And this is how we end each session then. Okay. And because we come from a global CBT mindset, we also include homework. This, again, will really depend on your personal setting. If you are in an outpatient setting where patients are very stable, their cognition has really recovered, and maybe they are very motivated to also do the work, then you can give them the homework to complete until the next session. There will be many settings where patients just don't do the homework. This has been our experience. I'm sure it has been other people's experience as well. And so we don't force the homework on patients. This is really meant as an option. So what we do here personally is we always take the homework with us to the session. And at the end, we ask, does someone want to take home the summary of today that includes some extra exercises? If you want to take it, if you don't want it, you don't have to take it. And then patients just can choose on their own. Because sometimes they will ask, do you have this written down somewhere? And then we can say, here, this is the homework slide. It is a summary of what we talked about today and then some exercises. If it is mostly about the exercises, then we have found that Cogito, our app that Dr. Zehut also mentioned in the beginning, is a really great way to do some out-of-session exercises because, you know, it's on your phone. Your phone will remind you if you put it into the settings to do a little exercise, and Cogito's exercises are very quick, so it will take like 3 minutes or something like that to complete. And this, we think in our experience, is something that is more convenient in everyday life to actually do. The app has some gamification elements. So, you know, if you complete an exercise, you get something for it and so on. And so we have also had great feedback from our patients who want to use the app. And so the QR code to download the app is also included at the end of each session, on the last slide of each session. And the app is also, again, free of charge. It has different topics. So the app is not only concerning psychosis. Some topics might also be relevant for our psychosis patients. There is depression, there is gambling or addiction related exercises, which might concern many patients, but there are also things like chronic pain and so on that might not be as relevant for many. So if you want to do this, if you want to use the app, you can just discuss with your patients which aspects of the app might be helpful for them. Or of course, they can choose themselves, of course. We also have these little yellow and red cards that were established also before we had the app. The yellow card is sort of a mini summary of what MCT is about, and we created them in a size that means you could put them into your wallet. And the idea is that if you get into a situation where you feel very uncomfortable, threatened, scared, anything like this, you can take out your little yellow card and ask yourself the questions that are written down here. And if this works, then this mental reframing of the situation might lead to a regulation of these adverse emotions, help you calm down, help you relieve some of the anxiety, of the fear, and so on. And this is also one element of how we try to transfer what we discuss in MCT into everyday life situations. And we have had some great examples of patients describing how this worked for them. So, and then the red card is just a very basic crisis card. This might be similar to what you already have in your settings, something that you already use with your patients. It's just meant as a little card of, if I get into a crisis, who can I talk to? so people can write that down and also put it in their wallet. These 2 cards we always give out to people who attend MCT for the first time. So we always have them with us. Every time someone new comes to the group, we ask them, would you like to take these cards? And they are also, again, this is the English version, but I'm sure there are translations of these cards also. The English versions are also available on our website to download. You would just have to print them on colored paper. And then we have group rules. This is just something very self-explanatory, something general. This is not anything specific to MCT. MCT is not different from other psychotherapy groups in that way. So depending on your setting, again, when we do this on our regular specialized psychosis ward, for example, we just have these rules printed out as a little poster, and then we attach it to the wall, and patients can see it at all times, read it at all times, and we can refer to it if we need to. When we work with patients who are very acute, who are on our psychiatric emergency ward, for example, who are in florid psychosis, it can be very helpful to reduce these rules to the minimum, like please treat each other respectfully, for example, and please let others finish speaking. And there we always read out the group rules in the beginning so that we can refer back to them, because as I'm sure you have experienced before, people who are in very active psychosis, they can sometimes talk a lot. It can be hard to kind of limit their part of the group discussion, so to say, and then it's helpful to just say, remember our group rules, please. Please let other people talk as well. Thank you for your active participation, but please also give room to the others, that sort of thing. Okay. Then where do you get the materials? This is what I said before. This is our webpage where you can get everything that I showed you before, in English at least, and we will have you know where you can get the Vietnamese versions of it. Right, so
I hope at the end of the years we can have the Vietnamese version. We are now at on the end stadium of the translations and adaptation.
perfect, thank you. And here, this is just going back to the app that I mentioned before. We kind of gave it the nickname, the toothbrush for the soul, because the idea was something that doesn't take long, just a few minutes each day will contribute to your mental health, just like brushing your teeth every day for a few minutes improves your dental health. And as mentioned before, it has different topics. This is mostly what I said before already. Also, I am not sure if anyone would be interested in this, but usually with these workshops, we are happy to provide the slides that I'm showing to you right now to you after the workshop, just in case anyone, wants to look back at what I showed you here before. You don't have to write any of that down or anything. I will be happy to provide the slides so you can look anything up that I went over too briefly or anything like that. Okay. Any questions or comments up to this point?
I think it's a question in the chat. So from Nguyễn Phương, maybe I will read that out. since your MCT program use an open group format, patient may not complete all the modules. How do you account for this when evaluating treatment outcome? Do you consider treatment doses or session attendance in your analysis?
Yeah, great question. Thank you. Yes, of course, you have to take that into account. And there are different ways of setting up the studies that you do, right? Some people are able to set studies up in the way that they attempt for all participants to complete 10 or even complete all 20 modules that we have and then do the evaluation then. And of course, you know, you will never have a participant pool that everyone completes everything, but you would have people attending most of the sessions this way at least. The more realistic your setting, or the more realistic the setting that you are conducting the study in is, the more you have to account for people not showing up, not attending every session. Also, the acuity of the psychosis plays a role, right? If people are acutely ill, if they are in florid psychosis, then they are more likely to not attend every session than if they are already well stabilized and attending MCT, for example, after a discharge from hospital. So what you mentioned already, these are definitely things we have to take into account, and many more things is what I'm trying to say. And yeah, one of the ways would be to just really keep in mind what is the dose and then see if it affects the response. And we have done work on that. Steffen Moritz knows the details of the many studies that have been conducted over the years better than I do. But I know these are questions that have been analyzed before. Yeah, thank you. Is there anything else for now? Okay, if not, then I will go on. And yes, please feel free to add questions in the chat. Yeah. Okay, so now I will show you the research that each of the modules is based on, and then show you how we implemented that in the training. Okay, so just for a brief orientation throughout the slides that I'm showing you, whenever you see this sort of slide, this is then a workshop slide, the presentation that we made. And whenever you see a slide that has this little guy in the corner, this will be an original MCT slide, part of the therapy materials, just so you can know where we are at. Okay. And so I would suggest, since it's 10:15 now, we might go through the first module right now and then take a quick break of maybe 10 to 15 minutes, if that's okay.
Yes.
Yeah, okay. Okay, so the first module, the first topic is attributional style. So the question of who or what do I attribute the things that happen to me to, or what is the reason for the things that happen to me? And there have been studies that show that people with paranoid schizophrenia tend to show an increased self-serving attributional style, meaning that they tend to externalize failures or negative events. So if something bad happens to me, it is because of the other person. And they have the tendency to attribute success or positive events internally, so to themselves. This is something that was shown in a lot of different studies early on, starting in the 90s. Professor Bentel from the UK and colleagues worked a lot on this. And this bias seems specifically related to people experiencing delusions. And what people in our lab also found when they were researching this is that patients who are experiencing current persecutory delusions tend to externalize both positive and negative events. So whatever happens to me, if it's good or bad or regardless, it is because of external sources. I don't have any control over this. And they tend to use monocausal attribution. So there is one specific reason why things happen to me. And especially this idea of externalizing all attributions can
Recording in
idea
progress.
in this questionnaire is that people are given different scenarios. They can be positive scenarios, they can be positive scenarios, negative scenarios, or neutral scenarios. In this case, it might be considered a negative scenario. So a friend cut you off while you were talking. And we always ask, why do you think this happened? So what caused your friend to cut you off? And participants are asked to first write down the major cause that they believe. So here they say the friend can be very insulting. And then what our lab added to this is this question of which part did the three aspects play in the event, and then to give a number between 0 and 100%. And in this case, this would be an example of an external attribution. So I am thinking this is because of someone else. This is not related to me, or I am not the cause of the situation. And it is a monocausal attribution in this example because I'm saying 100% of this reason is the other person. So there's no distribution of the 100 throughout the three aspects. And we basically took exactly this principle and then implemented it in the MCT module. So what we do is we discuss different scenarios, positive, negative, and neutral, and discuss their possible underlying causes. And then we also look at what advantages and disadvantages different attributional styles might have. And one of our main goals with this module is to get patients to realize that events usually are not monocausal, but usually there are multiple different things that contribute to a situation happening the way it happens. And so what I would like to do now is I would invite you to imagine you are a participant in our MCT group, And I will pretend now to be the facilitator of this module in this moment. I will present the slides to you as if I were doing the group. And I kindly ask you, when the exercises come up, to just give me your ideas of what you might think could be an answer. There's really no right or wrong way. I just, want you to get a feeling of how it might work. So you can feel free to just write answers in the chat, for example, or say them out loud into the room here, whichever is easiest. Okay. Okay. So
Maybe
well,
I could
yeah.
talk a
Yeah.
little bit, because it's because we have now the 3 room. We have the original audio, English and Vietnamese. So if you want to talk also in Vietnamese, and you want that is Dr. Fisher can hear you, so please change the channel to the original audio, so the Dr. Rabia Fisher can hear you if you can speak in English. And if you can want to ask a question in Vietnamese that are answer in Vietnamese, you can also write in the chat, so I can translate this. Yeah, thanks you.
Thank you. Okay, so welcome everyone to today's session. We are talking about attribution, which means blaming and taking credit for situations. And as many of you who have been here before will know, we first start by asking, okay, what does this even mean? So what attribution means is to infer causes for events. So for example, when we blame people or ourselves or take credit for situations. And in everyday life, we often overlook the idea that the same event can have multiple very different causes. So here we have an example. What causes could could have contributed to the following situation? You arranged a meeting with your friend, but your friend does not show up. So just your first thoughts, your first ideas. Why do you think your friend did not show up after you arranged a meeting with him? Please let me know what you think. Because he or she hates me. Yeah. He is busy with something more important. Yeah. He had an accident. Overslept. Yeah.
You don't take me serious.
Yeah.
And he ghosts me.
Yeah. Yeah, so I think there are some more Vietnamese answers. Tom, if you can help me.
Translate. So he ghosts me, he had something to do immediately. He had something, so he is a little bit late. He forgot.
Yeah, great, thank you. Yes, so immediately we see that we have different ideas of why this might be the case, right? And from your answers that you gave me already just now, we can see that there are different categories that we try to find our answers in. So usually we look for explanations that have to do with either ourselves, right? Someone said I'm not important to him, or someone said he hates me, right? Things like that, this sort of thing. Then another category where we look for reasons might be other people, right? So there were different examples that you gave already also, right? So he forgot, I think several people said, right? So this is a classic example of the other person, right? He forgot, he lost track of time, this sort of thing. Or we can look in the category of neither myself nor another person, but it's just the situation, the circumstances, or maybe this is just chance, right? So I think someone said he had an accident as an example, right? Here we have his car broke down as an example. So things like this. So great ideas that you have also come up with. We have wrote down similar examples here, but the idea is just to say that we look into the categories of myself, other people, or a situation or chance, usually. And the way we attribute things, or the reasons that we tend to find for things, impact how we feel in everyday life. And I would like to give you an example now that might also be very European, very German specifically, perhaps, because it is a soccer player. This just goes to show that Professor Moritz is a huge soccer fan, which I believe is how this example came to be. So here we have the situation that this is a soccer or football player, and his team lost 0-1 in this game, and he's being interviewed by a reporter. And the reporter says, if you had played better, the other team wouldn't have scored a goal. And so if this soccer player now says, okay, this is all because of myself, he might say something like, that was really my fault. I owe an apology to the fans, this sort of thing. What do you think might be the advantage or a disadvantage of saying, yes, this is all my fault, I am the reason why we lost this game? For example, how would he feel then if he says, this is all my fault? Please feel free to also give some options in the chat for either disadvantage or advantage.
Nếu mà đổ lỗi hết cho bản thân mình thì cái điểm lợi là gì và điểm không lợi là gì? Mọi người cũng có thể viết vào trong chat để chúng tôi biết rằng là mọi người cũng hiểu một chút câu hỏi và cũng
Yeah, he blames himself, exactly. Yeah, and as I said here, it reduces his confidence and he can feel stressed. Yeah. Yeah, self-blame and reduced confidence. Yeah, exactly. And this is also exactly what we thought, what we wrote down here. And someone also said, as an advantage, you take responsibility, right? So other people might view that positively, exactly. And you can learn from your mistakes. That's a very fair point, right? And this is exactly what you said were the same ideas that we had here also, exactly. Yeah. And so now if we look to the other example, so the journalist says, if you had played better, the other team wouldn't have scored a goal. And now the soccer player says, no, this is all because of the other people, or this is all because of the situation. So he might say, but where was the keeper? It is the fault of the keeper because he let the ball through. Because of him, the other team scored. Or he can just say, oh yeah, whatever, anything can happen in a soccer match. Today was just a bad day, this sort of thing. What do you think could be an advantage or a disadvantage of this? How might he feel then, for example?
Hại là
Yeah.
bị ban, đồng đội ban.
Yeah. Exactly. The team will not be happy if he says, it's not my fault. I don't care. Yeah, exactly. Someone also said anger in the chat, right? Yeah, his teammates will fight him. Exactly. Yeah. And someone also said, someone already gave answers to both questions earlier and said the advantage here is the opposite of up here. So if I say, well, that's not my fault, it's the other people's fault, then I don't have to blame myself, then that doesn't affect my self-confidence. So in this case, if I say it's all because of the others, then my self-esteem is not affected negatively, right? So here it's mostly the disadvantage. Other people might be angry. Also, I take the chance from myself of learning from my mistakes, definitely, but I don't have to feel so bad about myself. So they are kind of the opposite of each other. Exactly. Yeah. Thank you. Yeah, they can protect their ego. Exactly. This is what I meant. Yeah. And the disadvantage is they can't resolve the problem. Yeah, exactly. And this is also what we wrote down here. So exactly as you said. Yeah. Okay, so why are we even talking about this? Why are we doing this? Studies show us that many, but not all people who experience depression tend to blame themselves for their failures and tend to give others or the circumstances credit for their successes. So if something bad happens, it's my fault. If something good happens, or that's just luck, or yeah, it's because this person helped me, or something like this. And as we've seen before, this may lead to low self-esteem. On the other hand, studies have shown that many, but not all people who experience delusions tend to blame other people for negative events and failures, and sometimes tend to think that all events are beyond their own control. And especially the first attributional style may lead to interpersonal problems. As we've just said, if the soccer player says it's all everyone else's fault, then his team gets angry at him. And this is the same in other situations as well. Okay. So thank you so much for participating in this section of it. I will just briefly get back to moderating the workshop, so to say. So this is then one of the exercises that we do, and we will have many, many different scenarios like this one. So here again, if you want to do this, just choose the exercises that are the best for you or for your context. Here again, we have negative events, positive events, and neutral events. This would be a negative event, of course. I fail an exam. And then we always ask, why did you fail? What do you think is the main reason? Yourself, another person, or the circumstances? And then patients are, like we did before, asked to come up with reasons. And then, and this is not included here specifically, but what we will do, especially if patients are up to it, if they have the cognitive capacity in that moment to do this, we try and ask, okay, so you said, you know, maybe I didn't study enough, and someone else just said, maybe the teacher asked really hard questions. A lot of the time, it's not just one reason, but it might be several different reasons at once, right? So can someone think of a scenario where several reasons play a role in this event happening? So if your group is very active, if they are, you know, really understanding what's going on, then they might be able to come up with an explanation at the end that said, okay, I was very tired. I couldn't sleep that night because my neighbor was being very loud. So that would be circumstance. I also didn't study enough. I thought it would be okay like this, but it wasn't. And also, since the teacher asked very tough questions, I wasn't able to pass with not studying enough. So 3 different components that all contributed to this event. And we always repeat this throughout the exercises again and again to have the participants get used to this idea of most things in life do not have one monocausal attribution. There's not one only reason for this event, but usually many different things interact for a situation happening the way it does. Okay. And as I said before, we would then ask, okay, we're now coming to the end. What do you think were the learning objectives today? What were you able to take away from today's session? And then people say what they took away, and then we say, yes, this is similar to what we came up with. So we want you to remember to always consider different factors that could have contributed to the outcome of an event. So yourself, others, and circumstances. We should try to be as realistic as possible in everyday life. It's not justified to always put the blame on others, just as it is not always our own fault when things go wrong. Usually, many factors contribute to an event. And what does this have to do with psychosis? many people with psychosis tend to explain complex events with one single reason only. Sometimes other people alone are blamed for one's failure. So here we have an example of Anna, who continues to fall while she is walking. And her own belief is that her uncle caused this by sending pulse signals through electrodes in her head that make her lose balance. But another explanation might be that she had an ear infection, which affects her sense of balance. And it has also been raining for weeks and the streets are very slippery. So these might be factors that contribute to her falling frequently while she is walking. Yeah, and this is just a second example of the same principle. And this is how we would end the first session. Are there any questions, comments so far for the first module or anything else?
I saw in the comment that there is a question asked, what proportion of participating patients has shown positive outcomes in empirical studies?
What portion? Okay, so maybe it's easiest if we address all of the research questions at the end, because we do have a section at the end of the workshop where we go into more detail on the research findings, because there is a lot. It would be hard for me right now to kind of give you one specific number in a way, because it can be different throughout studies, and the proportion of how many show positive outcomes, again, it's a very complex question, right? So how do we define positive outcomes? That may be different from study to study, and how often we don't necessarily calculate it in proportions, even though that is a very interesting question, and I'm sure there are studies out there who did that. What I will show you later definitely is the average improvement in things like delusions, positive symptoms overall, quality of life, depression, other outcomes that you can choose. But usually, as we say, it is an average improvement over the group, right? So we usually don't go with binary outcomes of the proportion, but it is an interesting question, and I'm happy to just look that up and add it later.
And the other question also.
Yes, there is another question. Does suggesting examples to the client reduce their autonomy?
Can you maybe say what you mean by suggesting examples specifically, so that I know exactly what you're referring to? Maybe, oh, sorry.
Bạn Dung có thể nêu ví dụ cái việc là gợi ý ví dụ cho thân chủ có làm mất tính tự chủ của thân chủ không? Có thể giải thích cụ thể hơn là ý của bạn là như thế nào và đưa một vài ví dụ được không ạ? Also, he told us that is some suggestion like some you know, it's some reason of things such as like if you forget to do the homework, maybe because that you cannot do this. So that is the suggestions.
Yeah. Okay, then I understand. Thank you. That's a very good question. It really depends. So we try to really make sure in this training that whatever we suggest are just options, right? This is never the truth. So for example, if we go back to this exercise, for example, and then patients in the group, one person says it's because the teacher gave questions that were too tough, but then there are no answers from the group for yourself or circumstances, then I will just give suggestions that I can think of, right? Then I would say things like, it's because I didn't study enough. If it is more in everyday life outside of this training, then you can use this as a tool, right? So it can happen, of course, that if I say, hey, Mr. Patient, were you late because you overslept? And then they get angry at it. Or if something negative happens to a patient and then they tell you, oh, this is all just because my mother didn't do this right or something like this, then we can talk about that, right? We can say, okay, I realize that right now, in your view, this is only because your mother didn't do something right. If we sit down and think about it for a second, do you think there could also be other reasons? And then sometimes a person will say, no, this is the only option, right? And then I can say, if I think about the situation, I can also imagine that whatever also played a role, right? Or I can say, I've heard of a similar situation, or even with this, it depends on your personal style, but I say things like, oh, I once failed an exam because of this and that. So if I can give examples from my own experience, the patient doesn't have to necessarily believe me, right? It's not about them saying, oh, right, now that you are saying this could also be a reason, I am not thinking that this was because of my mother anymore. It's not about trying to convince them immediately. It is more about always reminding them that there might be other possibilities out there. There might be other reasons. There might be other ways of looking at it. So we can use it in everyday life. Depending on how you phrase it, they might not be happy with you. Yeah, that can happen. But if you phrase it in a way that is not very confrontational, usually patients are fine. Does that answer the question?
Nhưng mà tất nhiên là nếu mà bệnh nhân mà muốn có những cái lý do khác mà trả lời được ngay thì mình sẽ sử dụng ngay cái lý do của bệnh nhân. Tuy nhiên là mình sẽ thêm một vài các cái ý tưởng khác nữa để cho bệnh nhân mở ra. Nghĩa là để cho bệnh nhân, quan trọng nhất là mình phải gieo vào những cái nghi ngờ về những cái nhận định của họ. Mình sẽ gieo một số những cái nghi ngờ vào trong nhận định của họ, bởi vì đôi khi họ nhận định quá nhanh. Cái vấn đề lớn nhất của các bệnh nhân là họ nhận định, họ đưa ra những cái nhận định, họ nghĩa là jump in conclusion, tức là nhảy vào những cái nhận định rồi quy kết rất là nhanh, đưa ra kết quả thay vì là dừng lại một chút và thấy rằng là có nhiều nguyên nhân khác trong cuộc sống. Xin cảm ơn mọi người. I think it's now maybe we can have some break.
Yeah, I think so. So there were a couple more questions in the chat. Steffen and I were kind of answering them already. So if there are any more questions, please also feel free to put them in the chat. So if we don't get to them now, we could save the chat and then just look at it during breaks or after the workshop, and then we will try to get to them. But yeah, I think so. So now it's 10:55 where I am right now. Should we just say 15 minutes so we meet back at 10 past?
Maybe 10 minutes.
10 minutes?
Yes, because we are now a little bit longer. Because
Okay.
it's longer than we planned. So I think it's a 10 minutes.
Okay.
So everybody, we see each other again at 11 5.
Yeah.
So see you later.
Tom, hast du ganz kurz Zeit?
Ja.
Wunderbar. Könntest du mir noch mal den Link zusenden mit den Modulen? Ich werde versuchen, das in den nächsten Stunden auf unsere Webseite hochzuladen, wenn du erlaubst.
Ja, ich schicke dir.
Super, vielen, vielen Dank.
Ja, danke, ciao.
Okay, so I think it has been about 10 minutes. So I will just slowly start again, and hopefully everyone can come back. So just to also add to what has been discussed in the chat already, and thank you for all of your great question and discussion points. It is important to know that not every single bias that we have here is equally important to every single patient or person. So what we mainly want to do is to make them aware of these bias, because many patients will not be aware that they have them, like the attributional bias or the jumping to conclusions. They might not be aware of that, and just knowing that this is a thing can already help them a lot to better understand and to make different choices in the future. But if something is not as relevant to the individual person, that is completely fine. We have an individualized version of MCT where we would not go into detail on biases that are not relevant for the individual patient. Okay. So I will now go to modules 2 and 7, and then we will go through all of the modules. Just so you know, module 1 we did very extensively, specifically so that you get a first idea of what the modules might look like. For the following modules, I will mainly show you the exercises, because the beginning and the end are basically the same idea, just for the different biases. So you know this already. And again, if you have any questions or comments, please just interrupt me or put them in the chat, whichever works. Okay, so jumping to conclusions. This is one of our core biases that we address in MCT. So we have found that people with paranoid schizophrenia tend to make unwarranted decisions on the basis of little information. So that would be the definition of the JTC bias, jumping to conclusions bias. And this has been demonstrated in many, many different settings, experimental settings, also with delusion neutral material. So one very common way to measure this is the BEATS task, which I will show you in a second. How it might look like in psychosis would be something like, I hear a clicking noise in the telephone line, if I have very old telephone infrastructure, that is. And the conclusion might be, I am being tapped or spied on. And the task that we usually measure this with is the so-called BEATS task. And this was one of the earliest researches into the cognitive biases in psychosis that we had. Specifically, Professor Philippa Garrity from the UK was someone who started this research also already in the 1980s. And what you do in the BEATS task is you have two containers with opposite proportions of different colored beads. So here we have one container that has mostly green and then a few red beads, and the other container has mostly red beads and then a few green beads. And the idea is, I am telling the patient, I am drawing beads from one of the containers. It is always the same container that I'm drawing from. I don't change the container. And after I take the bead out, I put it back into the container. And then I show the patient, okay, here I have a green bead. Which container do you think I am drawing from? And then the patient or the participant can decide it's container A or container B. And then the question is, do you already want to decide which container I'm drawing from, or do you want more information? Should I draw another bead and show you another bead before you make the decision? And then the person might say, yes, show me more. And then I show them the second bead. This is again a green one. And then the question would be, which of the containers do you think I am drawing from, container A or container B? Do you need more information, or do you want to make a decision already? And then this can go on and on and on and on until the person decides, okay, now I have enough information. Now I have seen enough beads drawn to confidently make the decision you are drawing from container A or you are drawing from container B. And what we find here is that 40 to 70% of patients with delusions make a decision after drawing only one bead. So if we go back to this, in this scenario, the person would have said, okay, that's enough. I've seen enough. I have enough information. You're drawing from container A, and I'm absolutely certain I don't need more information. And as mentioned before, patients are often unaware of this bias. And this bias can be exacerbated or can be enhanced through, for example, emotion arousing influences like anxiety-inducing music, or through stress. So this is also something that we emphasize in the training, that we say everyone jumps to conclusions sometimes, right? That happens to everyone. That is completely fine. We just have to be aware of it. We have to ideally notice it and correct it, or prevent it from happening in the first place. And we should know that especially when we are under stress, this is more likely to happen. So if you are very anxious, if you are very stressed, please just be aware that this is a tendency that we can have to just jump to conclusions too quickly. And especially if the decision is meaningful, this might not be an ideal way to go about it. So what we do then in the practical implementation is we discuss the advantages and disadvantages of the JTC, and we have two different exercises. The first part is fragmented objects that are successively revealed. I will show you this. And then the second part is puzzling pictures, which I will also show you. And the takeaway for patients here is that hasty decision-making often leads to wrong conclusions, or sometimes to seeing only part of the story. So I will now again act like I'm the facilitator and we are in this MCT group setting. So please, again, when we get to the exercises, give your thoughts in the comments. Just before I start, one thing on reading verbatim what is written on the slides versus finding your own way of saying what's written there. I would really base that on my audience. So if I have a group of patients who have a lot of trouble concentrating, for example, then it is easier on them if I just read what is said on the slides and if I don't change it very much. If I have a group of people who are very fit and active and they're really into it, it's easy for them to follow, then I can rephrase what is written on the slides a bit more. But I know from my personal experience, we have always been taught never read exactly what is written on the slides, always put it in your own words. Depending on your group, that might not be the ideal way to go about it. Sometimes it's easier to just read what is written on the slide, word for word. Okay, so Welcome everybody to Metacognitive Training today. Today we are talking about jumping to conclusions. What is jumping to conclusions? We often make snap decisions on the basis of very complex information in our environment. And sometimes we come to a conclusion without 100% proof. This is actually very often. We usually don't have 100% proof. And so for our everyday life, we should sort of aim for a happy medium between making a decision that is too hasty, where we risk making a poor decision, and being overly accurate, which might just take too much time. So how would this bias look in everyday life? Where would we encounter this? So, for example, if we see smoke coming out of a window and our first thought is, might this be a fire? And then the question would be, do you think this is a justified conclusion that in this situation, my first thought, I go with it, right? If I see smoke coming out of a window and I immediately decide this is fire, do you think this is justified? And what would happen if that is my decision? And then the second example would be, I see a man and he is babbling, his speech is not clear, and my conclusion is immediately, okay, this man is drunk. I am sure of that. Do you think that is justified? And what do you think would happen if I follow this conclusion? Does anyone have any ideas? Okay, I'm not sure if... Yeah. Example 2, I might stay away from this man if I think he's drunk. Yes, exactly. And the idea here is that this might be very hurtful, right? I might judge this man and think, oh, he is drunk, I feel uncomfortable, I'm going to stay away. But this might not even be the right conclusion, right? So there could be many different reasons for why this man is babbling. He might be taking medication, for example. He might have suffered a stroke or things like that that impede his speech. But if I just think he is drunk, then I might do something or behave towards him in a way that is very unjustified. And what might be a bit different is the first example, where if I conclude, okay, this is fire, then I might call the fire brigade. And even if in that moment I make a snap judgment and I am wrong, then the fire brigade comes, they see there is no danger and nothing bad really happened. But if I don't make this snap decision, okay, there is smoke, there might be danger, there might be fire, I'm going to call the fire brigade, then something dangerous might happen because I am taking too long to decide, oh, is this really a fire? Maybe we can wait and see, So sometimes in life, there are situations where it is justified to act quickly because I am not 100% sure, but it is very likely that if there is smoke coming out of a building, then there might be fire. Yeah, exactly. And the second example is like using one's own past experience to evaluate or interpret the current situation. We cannot be sure that the person is drunk. Exactly. So this is me being prejudiced, right? I come to this conclusion that might be based on my personal experience, but I might be wrong. So here, it could be, but it's not as probable as here. And also, if I don't act here, that might be dangerous. If I do jump to a conclusion here and I stay away from this man, then I might be insulting him. Exactly. So this is just to show that sometimes we need to make inferences without 100% proof, but we need to be careful with the consequences of those judgments. Okay, and then one other thing that we do in this module are the urban legends. And I am not sure, this might be one of the examples where we should really try and see if there are more culturally relevant examples that we can find for the Vietnamese version. So here the idea is that maybe you have heard of this urban legend that Paul McCartney of the Beatles actually died in 1966 and was replaced by a double. So the idea is that this is not actually McCartney here, but like a doppelganger. And there are several pieces of evidence or proof that people mention that are supposed to prove that this theory is real. And I will just go through this quickly. Some of the evidence that people bring forward are the license plate that says LMW, and people have said that this might stand for Linda McCartney weeping. Here, people also claim that he is deathly pale, and they point out that he is walking barefoot while everyone else is wearing shoes. They're also saying he is left-handed, but he is holding his cigarette with his right hand, and that his bass playing is said to have changed since 1966. So in these people's opinion, these are all proof that McCartney died and this is a fake person here. But then the question is that really believable? And in this situation, we can see that, okay, but there are also things like his appearance and his voice haven't changed. And this evidence that people cite does not seem very convincing. For example, the LMW could mean anything. And we actually know where this legend came from because it was a newspaper hoax. So a newspaper deliberately made up this story as a joke. And this is just an example to show how we can jump to very many conclusions based on very shaky evidence if this is just fitting with what we believe already. So here the idea is no, he most likely was not replaced by a doppelganger, and he also addressed this himself. by producing a solo album with the title Paul is Life, where the cover is also similar to the Abbey Road cover that was part of the original hoax, so to say. Okay, so now I will show you the first task. We will not do this task. I will just show you what it is. So in the following, you will see a series of pictures. It starts with one detail of the picture, and then we add another detail and so on. And this continues until the whole picture is revealed. And the task is to identify the object and to avoid both too hasty as well as too prolonged decision making. And in every step, we would discuss the evidence for and against each of the alternatives. So this is the first part of the picture. And the question is, what might be presented here? Is it a bridge, a raft, rails, a flagpole, a pile of wood, or a paintbrush? And in our MCT sessions, in practice, what we often do is we ask people to raise their hand, right? So if we were now all in a room here, I would ask who thinks this is a bridge, and then people would raise their hand if they think it's a bridge, who thinks it's a raft, who thinks it's rails, and so on. And since one of the questions is also how confident are you, you can also indicate that with how you raise your hand. If you raise your hand like completely up high, then you are very confident that this is the right answer. If you raise your hand like to a medium height, it would be I'm somewhat certain. And then if you raise your hand just very low, then it would mean I'm very uncertain that this is the right choice. And then we also see at which point people think they have enough information to make a decision. So, successively, I show more details of this. So here, for example, can we rule out something? Okay, a paintbrush is highly unlikely. And then would you make a decision now? And this, for example, is the step where most people say, okay, now I am confident that this is a raft. And there are several more steps that come, but then in the end you see that this is the right answer. And this is a very playful exercise, one that we can really do also with people who do have more trouble concentrating, because even if you don't pay attention for a minute, you can come back to it and you're like, okay, where are we? What can I see? What do I think this is? People can come back to it. And it also has, a factor of entertainment, so it's not as boring as some other things might be. And so many patients enjoy the MCT also because it has this little fun character. And there are some really cute pictures in here. This is not my favorite. There's a great one that's an elephant. We don't have it here right now, but what we can also see with this exercise in particular, we aren't able to do it here in this setting because there are so many people and we are online and all of this. But when we do this in a group, we often have this moment, which is often, as I said here, when before it was this and now I put this, where people are like, aha, okay, now I know which is the right answer. And this aha effect is one thing that we are really looking for people to experience. So the one aspect is to explain to people what jumping to conclusions is, and that is helpful and important. But another part is to show them through the exercises directly that it happens to them also, right? Because maybe in the beginning, when I only saw this, I thought, oh, this is a paintbrush for sure. And then I'm like, okay, what is this? I'm not sure. Oh, okay, now I get it. And then people see, okay, in the beginning, I thought it was something completely different than what it turned out to be. Okay, this is what you mean by if I make a decision too fast, I might be wrong. Right? So. And then the second type of tasks that we have here are to show that sometimes when we make fast decisions, we don't necessarily make the wrong decision. We don't necessarily see the complete picture, but I just saw the question, what if they got it right in the first attempt? Yeah, very good question. This is why we do several of these pictures in one session. So this is one of the exercises. They are fairly quick to do. It takes like 3 to 5 minutes to get through one of these pictures, for example. So if someone guessed right on the first picture, they might not be right again for the second picture, right? And it might even drive up their confidence. They're like, okay, for the first one, I knew just from the very first line, I knew this would be this. So maybe for the second picture, they're even more likely to be wrong and more confident in their wrong decision then, which is a great learning experience then. So definitely do several of these. And again, this is one of the exercises where patients might comment like, oh, you're trying to make this difficult for us on purpose, or you're trying to make fun of us, or how are we supposed to know this? Are you trying to make us feel stupid? And it's really important to not dismiss them, but to say, yes, these pictures are specifically meant to be difficult. And sometimes they are specifically meant to mislead you. This is not because we are trying to trick you, but we are just trying to show you that sometimes with our thinking, we get it wrong. You know, sometimes we all make mistakes in our thinking, and that is fine, that is normal. We just have to be aware of it. Great question, thank you. Okay, so task 2. Sometimes when I make a decision too fast, I might not make a wrong decision, but I might not get the complete picture either. So the question here is, what do you see here? And then most people will say like, oh, okay, I see like an old white man. And then some people might say, okay, I also see 2 people. There's like this man here, and then here this might also be a woman who's part of like his ear and his shoulder thingy. And then we ask, okay, can you see even more in this picture? And then if you look closely, then you can see that, oh, this hand, this is also a little dog lying on the street. So depending on how you look at a picture, you might see different things, or you might miss certain things if you don't look closely enough, or if you don't look long enough. So we do also have video clips. I might just skip over this one, but there again, you should probably look at which of the video clips would be fitting or relevant in your cultural setting. But these also can just mix up the mode of presentation. They are often very funny, very entertaining, and they can just break up this monotone of we're all sitting in the group and you're talking and I'm trying to listen, but I'm having a hard time concentrating, this sort of thing. So we have different videos that illustrate the specific bias that we are talking about. Okay, so Module 7 is again jumping to conclusions, and it just adds the idea of liberal acceptance, meaning that the decision threshold in people with schizophrenia, for example, is different than that in healthy subjects. So, for example, if you think of the TV show Who Wants to Be a Millionaire, it's like the quiz show, right? And some people, they have to be really, really certain that they are right to commit to an answer, and they think like, I am 93% sure, or like I'm 97% sure that this is the right answer. And because I am so sure, I will accept, or I will log this in as my answer. Whereas some people who have a lower decision threshold might say, oh, I'm like 75% sure that this is the right answer, but that is enough for me to say, yes, I will log this as the definitive right answer. Right? So this is what we mean by make a decision with a low level of subjective confidence. And the other aspect is that people with schizophrenia might consider explanations that healthy individuals would not take into account, which I'm sure you can immediately imagine how that would be related to psychosis. Okay, so Module 7, this is basically the same thing as Module 2, just with different examples and so on. And for the main exercise here, we use portrait, old paintings. And the exercise here is I show you the painting, and now the question would be, which of these 4 options do you think is the correct title of this painting? Please have a look at the painting, just see what you can see on this painting, and then from that, please see or think about which of the 4 possible titles could be the right title for this painting. D, grandfather's library. Yeah. Thank you. And if we were like in the situation, I would ask you, why do you think this? Right? And I assume you're thinking library because there are several books in here. There is an old man who's reading. Yeah. And then someone said B, absorbed in studies. Yeah, again, you know, I can imagine why you would think that. There's like the old man really like with his book and so on. Seems like a study place. Yeah, several people said this. But then I also saw someone saying A. Someone said The Visit. And if you don't mind, let us know why you chose A. Yeah, someone said it. If you look to this side of the painting, there is a little birdie here. And if we look closely, the old man, he seems to not really be looking down at his study materials. but it looks like he's actually looking straight to the window. And so this is actually also the title of this painting, and this is my favorite of all of the paintings, which is why I put this one in. But the other paintings are similar in the sense that all of these are generally possible, right? Someone even said this, all of the above. All of them are possible, plausible, more or less plausible, but in this case, all plausible titles. And the idea here is not for someone to get it right necessarily, but for everyone to first give their opinion. I think it's this, I think it's that. And then we ask them to explain why they think this is the right answer. And here, this is an example of if I just look very, very closely at everything, I might see the bird which I otherwise might miss. But of course, it could also be a coincidence here that some people just immediately see the bird and others don't. But the idea here is just the more information I can gather before I make a decision, the more confident I can be in making a good decision. And it's also important to consider the context, right? Depending on what my decision is, it may or may not be really important to make the right decision. So the example that we always use and that works well is if I want to decide on which socks I want to wear today, I can decide fairly quickly because it's probably not going to be very relevant or have extreme consequences whether I choose the blue or the green socks today. But if I want to buy a new phone, it might make a lot more sense to put more research into the different options and so on, so that I can make a good decision for myself, because a phone is a huge financial investment. And especially if I make decisions that also impact other people, that might lead to conflict with other people, then it can be really helpful to try and stop and gather more information before I make a final decision. So this was JTC. Are there any questions, comments regarding this? Yeah, some questions. Yeah. So with this exercise, same as the one in the other module, we can also ask people to participate by just raising their hands instead of giving an answer. This is a way to kind of make everyone participate, because if I just look around the room and ask who wants to give their answer, then they can choose, of course. But if I say, everyone, now please think about which of the options would be possible, And if you think you're absolutely certain this is the right answer, raise your hand very high. If you're very uncertain, you can raise it very low, and so on. People can also choose multiple options in this, of course. And so if I have a group where several people are very quiet, I would use this hand raising method. If people are very quiet in general, my tendency is to not be so confrontative I don't know if that's a word in English, so forward, confrontational maybe, with psychosis patients unless I know the person very well and I know that they trust me. If I think I can ask them, like, hey, Mr. Miller, you've been very quiet, what do you think? Then I'll do that. But if I am less sure about how they will react, then I will ask them often to, would you please describe what you can see in the painting? Right? So if I'm not forcing them to make a decision on the exercise, then I'm not risking them being ashamed by choosing the wrong answer. But if I just ask them, could you describe what you see in this picture, then they can't really do anything wrong, right? So I am more encouraging them to participate. I try to avoid forcing them to make decisions unless I know them well enough. Okay. What if a patient? Yeah. Okay, I think I answered that. And if they are unable, if they're just like, I cannot decide, then I just say, please just, there's nothing wrong, nothing to lose. Just see if you want to raise your hand for anything. But if they just say, I won't do it, then I don't force them, of course. If a patient in the group tends to make quick decisions based on their personal perspective. Interesting question. If a patient tends to make quick decisions based on their personal perspective and their decisions turn out to be correct most of the time throughout the session, could this unintentionally reinforce an unhelpful belief that they are always right? Very interesting question. I guess theoretically, yes. Practically, it doesn't happen that often because many of these exercises are so random that people aren't really able to get things right all of the time. But if they, say something like this, like, oh, I got everything right, I'm so good at all of this, then I just gently try to remind them, like, yes, that's great that you were right in the exercises. As we said before, it's not that hasty decisions are always wrong. It is just that they are risky. So especially with important decisions, even though you were right so many times, it can't hurt to just take a step back and make sure that you can make the best decision possible, right? So I would just try to encourage them to be slower anyways. But yeah, I see what you're saying. This is also a very interesting question. Doing all these might have a risk that it would make a subject think a little too much or too far from what's in front of them, and end up thinking too much and even choosing the wrong answer. Is that a part of the therapy? Well, I think since overthinking decisions can also be its own problem and might, for example, be a problem for people who also suffer from depression during other phases, right? Or schizoaffective disorder, something like that. So I think if the person has a problem with overthinking, then it is important to see that and to validate that. Making people aware of the possible tendency to jump to conclusions. Usually, as far as I know, but this is now just from my own personal experience, the experience from others that I know, and what I know from the literature, it doesn't happen in the sense that this would really cause overthinking in that way. So I understand your fear. I have not experienced it in this way, but I think it's important to also see that overthinking in itself can be a problem. I don't think it would be caused by MCT, because the examples that we use, they are not specific to the person's own life, right? They are delusion neutral on purpose. So they don't invite you to really overthink regarding these exercises. So I think it would be a very complex transfer in a way, which most people, I don't think, do. But it is a very interesting question. Could I add an activity to this exercise? For example, are observing pictures, patients, evidence that supports their interpretation? Absolutely. If you think your patients can do that, if they are able to do it, and just in general, I think this is very important. So MCT is open source, and as you can see, Steffen Moritz is always very open about just seeing what works in the specific contexts that you're in, right? So as long as you preserve the original idea of what we are trying to do, or if you end up doing something completely different, if you then don't call it MCT anymore, we are completely open to putting your own spin on this, even, coming up with your own exercises, adding new pictures, anything like that, that is completely fine. It would, of course, not make it standardized anymore, but it doesn't have to be standardized if you have a way to make it more effective for your population. Great idea, yeah. Yeah.
Tôi cũng xin trả lời nói chung là ngắn gọn thôi, bởi vì là mọi người cũng hỏi rất nhiều các cái ý kiến là đưa ra quyết định. Cái quan trọng nhất ở đây không phải là đúng và sai, mà cái quan trọng nhất ở đây là để cho bệnh nhân có bắt đầu kiểu như mình gieo những cái suy nghĩ khác, những cái quyết định khác, những cái có thể xảy ra cho bệnh nhân. Chỉ cần bệnh nhân nghĩ đến nó thôi là đã là thành công rồi, chứ còn không nhất thiết là phải là đúng và sai. Đấy, cái quan trọng nhất ở đây là những cái bài tập này là không phải bài tập để chúng ta thấy là bệnh nhân, cái quyết định của bệnh nhân là đúng hay là quyết định của bệnh nhân là sai, mà cái đơn giản nhất là để bệnh nhân hiểu được rằng trước khi mà mình đưa ra một quyết định, có khi là mình dừng lại vài ba giây, không phải là hoặc là chục giây để suy nghĩ là nó có thể là có các cái ý khác không, hay là có thể là mình sẽ đưa ra kết luận quá nhanh, có phải không? Đấy là cái quan trọng nhất, còn không quan trọng là bạn làm đúng hay bạn làm sai. Hoặc là bạn đưa ra cái quyết định đúng hay quyết định sai, bạn đưa được đáp án đúng hay đáp án sai ở trong cái bài tập này. Và ngay từ đầu chúng ta nên rõ ràng cho bệnh nhân. Đấy là để tôi hy vọng là nó trả lời cho một số cái câu hỏi ở đây. Thì tôi thấy cái điều quan trọng nhất ở đây là bệnh nhân chỉ cần là hiểu được rằng là nó có nhiều cái khả năng có thể xảy ra chứ không phải chỉ một khả năng. So some questions is about this, maybe is, you know, is there something like the if you have what is the concrete force decision, you know, I think is the most important. It's not the wrong or the right decision. It's much important to think about that is the patient have another idea and a little bit. Maybe you know, is something like take more time to get into the decision. This is actually the main idea of the exercise. So I just try to answer the question and to point that actually the main idea why we do the exercise.
Yes, thank you. Exactly. It's not so much about what is the right answer. Yeah. Okay. Should we go on, or are there any more questions or?
I think we can move further.
Okay. Good. Okay, so module 3 then. So as you can see, we are walking through it very, very quickly. So this is on purpose. We will not be able to go through all of the exercises, but hopefully you will get an idea. I'm not sure why this is happening, but right now I am hearing the translation. Okay. Okay, thank you. Okay, hopefully. Thank you. Okay, so changing beliefs. This is actually really also related to what we were just talking about, because the idea here is that, for example, in the exercises with the paintings, if I thought at first it was like grandfather's study room or whatever, but then I see the bird and then I think, oh, it might be the visit. My first thought might have been wrong and now I am correcting it. This is a mental exercise that most of us do all the time throughout our day, probably, but this is something that is harder to do for people with schizophrenia, as research has found. So this is the tendency of patients with paranoid schizophrenia to insist on false positions, and especially despite counter evidence, even for delusion neutral material. And we call this the bias against disconfirmatory evidence. And because that is so long, I will call it BAID from now on. So one way in which we can measure this paradigm is that we give patients pieces of information one after the other And based on the information patients have, they are supposed to choose one of 4 answers of what is going on. So in this example, there's the girl Heike, who is very thin. So this is all I know right now. And then the question is, what is the situation here? Is it she is a model? Is it that she is suffering from an eating disorder? Is it that she has lost all her false teeth? Or is it that she is homeless? And 2 of these possible explanations seem plausible at first. So if I only know that she is very thin, I think, yeah, she might be a model. Or I think, okay, she might have an eating disorder. That seems plausible, right? So if I only have this information, I would rate these 2 as fairly highly likely. Then we have one option that is always absurd. So I know she's thin, thinking it's because she lost her teeth. Unlikely. Okay. So I think this is unlikely. And then we have one option that at first seems implausible, or at least less likely, but with the additional information that I will receive in a moment, this will become more likely. So then I will get the second information, and then I will have to re-rate the likelihood, and then I will get the third information, and I have to re-rate the likelihood again. So now I know that she's very thin, she has had a hard life, and she does not even have a home. And now that I know all 3 of these things, and I look at the 4 explanations, I think, okay, not having a home and being a model at the same time, very unlikely. So when at first I thought this might have been the right answer, I now think, oh no, this is not very likely. And once I know that she does not even have a home, then I think, oh, the explanation that she is homeless is now the most likely. So these are the 2 corrections that I have to make. The things or the answers that I first thought were very likely, I have to correct down. And the answers that I thought were, or the answer that I thought was unlikely, I have to correct upwards to likely. It's a bit complicated, but hopefully you got the idea. And what we then can see is that the correction of the true sentence, everyone can do fairly the same way. So these were 3 groups: people with schizophrenia, people without a diagnosis, and people with OCD. All 3 groups were able to do this. So from it's unlikely to go to yes, this is the likely answer. This change all 3 groups were able to make. The difference that we can see is that patients with schizophrenia made this correction here to a lesser extent than patients with OCD or people without a diagnosis. So a person with schizophrenia might change this answer to something like 4 or 5, and might change this answer also to something like 4 or 5. So they don't rate it down as much. Okay, does that make sense? So this is the idea that they don't discard options that are unlikely, even when faced with evidence to the contrary. Okay, so then the question is, how do we do this in MCT? At first, we discuss the disadvantages of very rigid attitudes, such as cliches or even stereotypes. And then we present specific scenes that often have an unexpected ending. Okay, and the idea here is that the patients realize that sometimes we have to correct our previous judgments. Okay, so we are now again acting like we are in the MCT group training. Welcome everyone to today. We are talking about changing beliefs, and to start here, I have some quotes for you by people who made incorrect predictions and whose predictions turned out to be wrong. A favorite of mine is the first one: sensible and responsible women do not want to vote, is what a former president of the United States said in 1905. And of course, we now know that many sensible and responsible women do want to vote. There is also the horse, this one. The horse is here to stay, but the automobile is only a novelty, a fad, is what a president of a bank said. And of course, now we know that horses as transportation are not as common today, and that the automobile is very much not a fad. So the idea here is that we should stay open-minded about new experiences. Time changes, and no one can foresee what the future brings. Okay. So I would like to do a little exercise with you now. Here you can see 3 pictures, and the objects shown in these pictures all belong to a certain category. And I want you now to not guess the category, but to first give me more examples of other objects that you think fit into the category that I'm looking for. And if the object that you suggest fits into the category, then I will say yes. If it does not fit, then I will say no. And then once you think you are sure that you have the right category, then you can suggest a category. Okay, so please, if you would like, give me some suggestions for other objects in the chat. Okay, we have, yeah, okay, so, okay, there are some more answers coming in the chat. That's very interesting, thank you. So I think maybe I didn't explain it properly, and it's good. This is why I didn't skip this exercise, because this will happen a lot in the group as well. It is important for this exercise to work that you first give more examples of other objects that would complete this category, and not immediately try to guess the category, because, you know, someone said fruit, someone said exotic fruit, someone said something to eat. These are already the category, right? And of course, here the question is, what is the category? So this might be misleading. It is very important when you administer this exercise to first have people give more examples of objects. So, you know, ideally someone would have said raspberry or mango or melon or something like this first before guessing the category, because the point of this exercise is that we are not looking for the category fruit, but we are looking for the category something to eat or food. So this was the right one. There's also, right, for example, the idea, is it with or without nuts? Also a good point. But the idea here is that if I see these three pictures and I immediately think the category is fruit, which I think most of us thought when we first saw these pictures, then I will only suggest other objects that confirm my theory, right? If someone had said melon, I would have said yes. And the person might have thought, okay, a melon is a fruit. It fits my hypothesis that the category is fruit. But if I don't ask for something that is not a fruit, if I had said, for example, bread, then I would have also said yes. And that would have shown you that the category I'm looking for is not fruit, but something broader. But what happens, and this is called the confirmation bias, is that we often only search for the information that supports our assumptions, and we don't look for contradictory evidence. So this is why I wanted to do this exercise, even though it takes a bit of time, because just if you want to do this, make sure that you ask people to give further examples of things that fit into the category. And, you know, this confirmation bias in every day might look like we only read newspapers consistent with our own opinions, or of course, you know, all of the social media filters and so on. It's very relevant to our situation today, and it might lead to one-sided attitudes and even foster incorrect judgments. So again, this is a bias that we all have, but we should all just be aware of. Okay, this overall is a very complicated module, which is why we need a bit of time for it. So the next exercise that we have here is that I will show you a story in 3 pictures. And what is important is that the pictures will be shown in reverse order. So I will show you the last of the events first. And after each picture is shown, I will ask you to rate the plausibility or likelihood of each of the suggested interpretations. And then we have to reassess them every time a new picture comes up, and we will discuss in the group how confident you are in the rating. So this is the last picture in this story or in this scenario. What do you think is happening here? Is the conductor tense because he arrived late for rehearsal? Has he just yelled at the man in the front row because he was singing out of tune? Did the girl in the front row just tell the man next to her that she has a crush on the conductor? Or is the conductor nervous because he cannot find his baton? If you would like to guess, feel free to write down any of the numbers in the chat. Mm-hmm. Okay. Mm-hmm. Thank you. It is one of the 4 answers. That's a good point. Sometimes people in the group will also ask that. Is it one of the 4? Yes, it's always one of the 4. It's never like it's something completely different. Okay, so we have number 1 or number 4 would be a possibility. So if we were in the group, I would ask you to please tell me why you think it might be number 1 or number 4. For right now, we will skip this step, but you will have your reasons why you thought it's one of them. And we can also say that number 2 and number 3 at this point don't seem very likely to us. So we don't think it's one of those. So this is new information now. This is what happens right before this happens. And so my question would be, does that change anything? Do you think one of the answers is now more or less likely than it was before? Yeah. And I think, or I'm guessing, you think he looks shy because, you know, he's also blushing. He has the red in his cheeks. Yeah, exactly, right? So this is what we look for. And this is also one of the exercises where we could ask someone to participate by just telling us what they can see. And then if they want to, they can say why they think which answer is the correct one. But if the participant in our group is too shy or too uncertain to commit to an answer.